Namaste everyone, Dr.Jyotsna here. So let's know how to manage a patient with suspected stroke and the patient who is having intracranial hemorrhage. So first come first, A, B, C, D, E. After that, do a CT scan to rule out any hemorrhagic stroke. As there is a focal deficit, so show that there is some certain acute focal deficit, so they show that there is some stroke is going on. Which stroke we need to rule out? We need to rule out hemorrhagic stroke, because treatment totally changes. So if we are managing if there is a hemorrhage, so now hemorrhagic stroke, first thing is we have to do in things which does not increases the ICP further and which doesn't increases the hematoma size. To not let the hematoma size increase, we have to decrease the blood pressure if high. Generally it will be high only, so we need to decrease the blood pressure. If it is greater than 150 to 220, we have to decrease it down to 140. It will be better to be between 140 to 150, and if it is more than 220, then decrease first to get less than 220 systolic BP, and then further in over a period of hour decrease it further down to less than equal to 140 to 150, because ITERACT 2 trial has shown benefit with that. So what are the choices of antihypertensive? Nicardipine, clebidipine, these are the dihydropyridine calcium channel blockers, and these basically does not increases the cerebral blood flow, because it is not a cerebral vasodilator, it is a systemic vasodilator. And we can also use labetalol, which is a beta blocker as well as a alpha 1 blocker. But yeah, when we are giving lobate, we may have to be very careful about the sign of further raised IPCP, because it will decrease BP further, and because of the small reflex there will be hypertension, bradycardia, and there could be chances of respiratory depression. So if there is already BP is heart rate is going down because of the raised ICP, and we are giving lobate, it will be difficult to differentiate between two. So in our hospital we don't use lobate, we use calcium channel blocker either. We should avoid NTG or nitroprusside, because these increases the cerebral blood flow and which can further increase the ICP. So by just see the difference. If there is a ischemic stroke, then in that case we don't have to decrease the BP until we want to thrombolize the patient. If we don't have to thrombolize, if it's out of window period, or we are not going to thrombolize because of any contraindication, then in that case, in ischemic stroke, we don't decrease the BP. And if we have to decrease, we have just to decrease less than 180 systolic and less than 105 diastolic for giving thrombolytic therapy, and for after that we have to maintain less than 180 for the ischemic stroke after thrombolysis. But if we are not thrombolizing the patient in ischemic stroke, we don't have to decrease the BP if it is not hypertensive emergency, and we don't decrease the BP further. So that is the thing. We have to take care of that and that, until the BP is like greater than 220, and so we may have to in that case we may have to decrease BP a little, but we don't decrease BP generally if it is we are not thrombolizing, and if the BP is less than 220 and no sign of hypertensive emergency. because there is regulation is on the higher side, and to save the penumbra, perfusion of the penumbra, we need to maintain the BP on the higher side only in such patients of ischemic stroke. So let's come next. These the hemorrhagic stroke, we need to correct the coagulation profile. We have to hold all the antithrombotic agents, anticoagulant or antiplatelet agents if the patient is on, and if required we have to reverse it. I had a patient with hemorrhagic, as I have told you that there was a patient who came after dialysis. Although the dialysis time was more than 18 to 20 hours, so he has received heparin, and protamine will not work. So because after 18 to 16 hours, so it's useless. But in case it is heparin has been given, it is less than 2 hours or than 3 hours, we can give protamine accordingly. So if it is warfarin, patient is on warfarin, we may have to give vitamin K, FFP, factor 4 PCC, or if the patient is on NOAC, 10A inhibitor, we may have to give androxanate alpha or dabigatran. We may have to give idrasuzumab. So according to the medicine which patient was on, anticoagulant or antiplatelet patient was on, we may have to correct the coagulation profile accordingly. So coagulation profile is also always sent, and we have to take the history properly. So these are to reduce the hematoma expansion, and whenever we have to continuously monitor this GCS, and for the focal neurological deficiency, new focal, if any such thing is there, we immediately have to repeat the brain imaging. So now, how to decrease the raised ICP? Keep the head in the neutral position, and head of the bed should be raised to 15 degree. Then don't put any internal jugular cannulation. Try to avoid it because it will decrease the cerebral blood flow, venous return. Give hyperosmolar agents like mannitol or 3% NS according if there is sign of raised ICP with or sign of brain herniation, and or you are trying to buy time just before going OT. So in those cases you can give this hypertonic saline or hyperosmolar agents, but be very cautious and to keep the osmolarity, serum osmolarity less than 310 to 320, and sodium less than 150, less than equal to 150. It should not go more than 160, because these can further deteriorate the patient, because there is a chances of osmotic demyelination. Indication of surgery. What are the indication of neurosurgical reference we should always take in the beginning only, but in the urgency, what is the neurosurgical intervention? According to ASA, American Stroke Association Guide 2022 guideline, they say any hemorrhagic any cerebral hemorrhage greater than 3 cm or cerebral hemorrhage with low GCS or sign of mid brain compression or hydrocephalus, we have to go for decompressive posterior fossa decompressive craniotomy. If there is a superficial lobar hemorrhage which can be approached from superficially, we can hematoma evacuation and decompression craniotomy can be done. If there is suppose there is a deep seated like basal ganglia hemorrhage, we should not approach it because there is less chance of benefit than worsening the patients. So basically these are the two conditions. If it is a cerebral hemorrhage with greater than 3 cm or there is a compression or low GCS because of the cerebral hemorrhage, compression of the brainstem, or there is superficial approachable hematoma. Hematoma size could be greater than 30 ml or midline shift could be more than 5 centimeters. So these are the indication for surgery. Same thing is echoed by the European Association, Stroke Association as well, and ITERACT 2 trial has also showed benefit in the functional benefit with early intervention with the surgery in these type of patient who has cerebral hemorrhage or superficial hemorrhage. So anticonvulsant is not advised routinely, but yeah, if the patient is having, there is a chances of cortical bleed, there is a chances of seizures, so we may have to give anticonvulsant if seizures develops. Otherwise routine requirement is not there. So after this initial management, we have to also take care of the any DVT prophylaxis. Once the initial phase has gone, we may have to give anticoagulant as well. Till then, a DVT stockings or DVT pump can be used. Stress ulcers prophylactic is usually not advised, but according to the patient condition, one can give. The pressure sore injuries are possible, so we have to take care of that. Frequent size change, chest and limb physio, rehabilitation starts from the beginning only. So we have to take care of all these things. Aspiration, there is a chances of aspiration. Already I have spoken about A, B, C, D, E. So you can take care of that. Thank you.